The session is going to be about essential targets of septic shock. So we thought the best way to get you out of your soup coma is to start with Jan-Lui speaking about arterial blood pressure. Too much information?
Thank you very much, Mr. Chairman. Is blood pressure important? That's the question you are asking me. I'm sure we all agree that we need to maintain a minimal arterial pressure for the tissues to function. But what is this value? Perhaps initially we could say 65 in septic shock, or actually in other disease states, perhaps a bit higher in patients with a history of hypertension. In this review paper that we recently published with our friends from Marseille, we reminded the reader that we are looking at autoregulation curves of the various organs. We know it very well for the brain, but all the other organs have their own autoregulation curves. And we want to avoid being on the ascending slope of this relationship. Now, this slope, of course, can be shifted to the right in patients with a history of hypertension. Now, I am member of the Committee for the Surviving Sepsis Campaign, and we agreed that in sepsis, or septic shock rather, we recommend that vasopressor therapy initially target a mean arterial pressure of 65. We wrote initially, and people just lost the word. And they said, okay, septic shock at 65. We never said that, no. And actually, our French colleagues then, there's this big study, everybody knows this study, you know, targeting two different blood pressure levels, no difference in outcome. How do you interpret this? I think there are two possibilities. One is that if blood pressure doesn't matter, that's one possibility. The blood pressure doesn't matter in septic shock. If this is the case, we should no longer measure it, right? Some of you may know my MIA rule, measure, interpret, apply. Actually, it will appear in print now in the British Journal of Anesthesia. If you do not do anything with your measurement, don't measure it. There are so many people who are happy to measure cardiac output. Cardiac output is at 5 liters per minute, 6 liters per minute, 4 liters per minute, and they don't do anything about it. So if it's the same for blood pressure, then we should stop measuring blood pressure. But I don't think we would go in that route. We think it's important. We like to measure blood pressure. So the only other explanation is that blood pressure should be individualized. But I thought we knew that before the study. I think this study was useless. That's my thought about the study. That's the scheme. You randomize patients for 2 blood pressure levels, no difference in outcome. To me, it means that in the high blood pressure level, some patients may have benefited, especially elderly patients with atherosclerosis. But other patients were harmed by more fluids, more vasopressors, when they had actually good vessels, no history of hypertension, they didn't need a higher blood pressure. And the same is true for the other group with a lower blood pressure. Some patients who are young without atherosclerosis may be very happy with a lower blood pressure. And elderly patients with atherosclerosis may have an insufficient blood pressure when they are in the lower blood pressure group. So, blood pressure target should be individualized, exactly like cardiac output values. And I think these are good news, because otherwise people would use simple protocols. That would be a shame for us. We like to be at the bedside. We like to evaluate the patient as we change things in the treatment, right? So how can we evaluate the adequacy of blood pressure? Well, clinical evaluation should come first, before we rely on other variables. And the clinical evaluation should basically include the three windows of acute circulatory failure. What about the skin, diuresis, and brain perfusion, the mental status? These are the three windows, right, of tissue perfusion. And then we can complement it with SVO2 and lactate. That's exactly what we recommended in our European consensus document. We recommend initially targeting a mean arterial pressure of 65. That was in shock in general. We recommend individualizing the target blood pressure during shock resuscitation. That's for trauma. We may afford a lower blood pressure in the bleeding patient. And then we suggest a higher blood pressure in patients with history of hypertension and in patients that show clinical improvement. When you try, we often invite the nurse to actually tell us what the blood pressure is optimally, what the optimal blood pressure is. Too often, it's the doctor who say, it should be, blah, blah, blah. And the nurse, okay, I will do that. It should be the other way around. The nurse should tell the doctor, I realize that when the blood pressure is at 72, 73, now I can see some urine output coming out. If we are facing a patient with a low blood pressure, well, first of all, we need to see if really this is associated with acute circulatory failure, right? Sometimes the resident says, well, yeah, there is hypertension plus altered organ function. The patient is hemodynamically unstable. Do you mean the patient is in shock? Well, yeah. They're afraid. They're afraid of the word shock. Let's use the word. We have invented the word. Let's use it. For patients who have hypotension, with tachycardia, but that's not very specific, and who have an alteration in brain function, not coma, but obtundation, disorientation, alteration in skin perfusion, and in urine output. These are the three windows to look into the body. And then we have the lactate levels, above 2 milliequivalents per liter. So blood lactate levels are not a sepsis marker. I have heard some people saying, lactate is a sepsis marker. No. CRP, procalcitonin, not lactate. Lactate is a marker of altered tissue perfusion. So it can be increased in septic shock. It's not increased in sepsis without shock. It can be increased in other forms of shock, being hypovolemic, cardiogenic, obstructive. And, of course, we need to repeat lactate levels over time to appreciate the kinetics. This is not lactate clearance. We sometimes hear people speaking about clearance. They have not understood the concept. The concept is that you repeat the levels and you make sure that they go down and they don't go up, right? And it's primarily the production of lactate that you evaluate by repeating lactate levels, not so much the clearance. So, to summarize, if we are looking at a patient with a low blood pressure, and if the patient says, hello, doctor, yeah, everything is fine, probably we should not jump on that patient, right? If there are signs of altered tissue perfusion, then we check the blood lactate level. If it's elevated, we need to introduce an arterial catheter, correct? And I would say a central venous catheter as well. We will see what the next speaker will say in a moment. But that's what our European consensus also says. The next thing is, what is the cause? Now, in this case, this is a session on septic shock. The sepsis, hopefully, will be evident. I'll speak tomorrow more about the management of these patients and what kind of monitoring we need and how we need to look at cardiac output and SVO2. I'll do it at lunchtime tomorrow. But today, as we are focusing on the variables, I will say that problematic hypotension requires an arterial catheter. Clearly, because we want to follow it over time. And clearly, diastolic blood pressure is important. Sometimes the resident just reports a systolic. In the ambulance, it's okay. When you just evaluate the patient first, it's okay. But otherwise, we should not focus only on systolic. The perfusion pressure depends on the mean, after all. That's true for all organs, for the brain, for any other organ. And the diastolic pressure will play an important role in tissue perfusion, in particular in the coronary perfusion. So we should not dismiss the importance of diastolic blood pressure. And if the diastolic pressure is low, that's a further indication for correction, especially in elderly patients who may have some coronary artery disease. Finally, a problematic hypotension should always be corrected immediately. In the past, we were writing in our papers, in the method section of our papers, that vasopressor support was added when hypotension persisted despite fluid administration, right? You have seen it many, many times. That's wrong. That's wrong. Because if the patient has a poor response to fluid, why would you wait? Why would you keep the patient hypotensive for a while? You should correct it with the transient use of vasopressors. And even if the patient responds to fluids, why do you wait? Why don't you correct this hypotension rapidly? And there is now plenty of evidence in surgery, in the ICU in general, indicating that any hypotension can be associated with worse outcomes. This is one of these nice studies showing that in septic shock, if you can avoid this hypotensive phase, you may find that the lactate levels actually increase less, suggesting a better tissue perfusion. But it makes sense. It makes sense. Why would we keep a patient hypotensive? Do you remember these studies where they said patient remained hypotensive for 1 hour to be entered in the study? That's old stuff, totally obsolete. So clearly in the VIP rule, we need to do the three at the same time. Oxygen therapy, intubate the trachea, if necessary, give fluids, give vasopressors, VIP altogether. But of course, as soon as possible, we should try to wean the vasopressor agent. And I spoke about the vasopressor, but clearly in the initial vasopressor therapy, as we showed, noradrenaline is preferable to dopamine. In this paper, the differences were statistically significant for cardiogenic shock. They were not statistically significant for septic shock. But then we did a meta-analysis, and indeed, we could conclude that in septic shock 2, noradrenaline is the vasopressor agent of choice. If you want further meta-analysis, this is one published very recently. Same thing. Same thing. Noradrenaline is better than dopamine. And this is a large North American study showing the same thing, that in real life, in a large population, the use of dopamine was associated with higher mortality rates. So really, we should get rid of dopamine. If there are pediatricians in the room, well, you know, there are some recent data showing that dopamine may not be the best drug in pediatric septic shock. Although I just found this morning a recent prospective randomized control trial, double-blinded, but with only 60 patients. But it showed that epinephrine may actually be worse than dopamine, or dopamine may be better than epinephrine. But epinephrine is not our first drug for hypotension in septic shock in any case. So dopamine is not the first choice. Adrenaline is not the first choice. Finally, no excessive vasoconstriction. Today, when people have hesitations to use hemodynamic monitoring, they sometimes just measure blood pressure and give vasopressors according to the blood pressure. That's dangerous. Blood pressure is determined by cardiac output and resistance, right, and vascular tone. And in septic shock, cardiac output is increased, vascular tone is decreased. But with the excessive use of vasopressors, cardiac output may actually go down. So if we use only vasopressors, we may actually end up with multiple organ failure. Clearly, we don't want to give too much fluids to our patients, okay, but it doesn't mean that we should limit fluid. We should respect these SOSD phases, and at least initially give enough fluid to avoid excessive vasoconstriction. And the addition of dobutamine, even in the absence of documented heart failure, may be valuable, and we recommend it with the Surviving Sepsis campaign as well. Because if we want to increase oxygen delivery, transfusions, fluids, dobutamine are the options. So we end up with noradrenaline for blood pressure and dobutamine for cardiac output. And of course, we need to treat the cause of the hypotension. We should not focus only on the hemodynamics. We need to restore tissue perfusion and treat the cause. So in conclusion, hypotension associated with altered tissue perfusion must be corrected promptly. We should not allow a patient to remain hypotensive if there are signs of altered tissue perfusion. Once again, there are patients who are chronically hypotensive. But shock treatment requires more than vasopressor therapy. So later on, we need to come back with fluids, perhaps with transfusions, with dobutamine. Arterial pressure should never be considered in isolation. Except initially, if you tell me that the patient is 40 systolic, the patient is about to die, we just correct the blood pressure. But then we will think and we will see at what we can do to increase oxygen delivery to the tissues, keeping in mind that the cause must, of course, be controlled. Thank you very much.